not present. I will start from the beginning. Okay. So there are many different types of adnexal masses present, and it can be very confusing. But luckily, there has been a big effort in the past by Professor Testa, Professor Valentin, Professor Timmerman, and many colleagues that have worked very hard on these imaging and gynecology papers published in the White Journal. So every of these papers has as subject one of the particular types of ovarian masses and describes the clinical and ultrasound characteristics. And recently, there was also a published consensus here last year by ISUOC, IOTA, ESGE, and ESGO. And in this consensus guideline, you will also find a very clear summary of the most typical features of different adnexal pathologies. But to make it a little bit easier for today's session, we will focus on two types of adnexal masses. We will talk about some germ cell tumors. We will talk about two of them. And also we will talk about two types of stromal tumors. You know that besides that, there can be epithelial tumors of the ovary and also sometimes metastasis from another primary origin. So these are the lesions that we will focus on today. From the stromal tumors, we will talk about the granulosa cell tumor and the fibroma. And from the germ cell tumors, we will talk about dysgerminomas and immature teratomas. And now we'll hand the word to Chiara to introduce some cases.
Thank you, Wouter. So, I'm very happy to be with you, Antonia, and with you, Wouter. So we're going to be a little bit interactive.
Yes, of course.
You are a great expert, so we are going really to have inspiration.
We will see.
So we start with the first case. This is the lesion which was scanned. 52 years old, postmenopausal patient, presented with pelvic pain. So we have still images in gray scale and in color core. So if you would describe the type of adnexal tumor.
Type?
Yes, I
What
mean
do
the
you mean?
morphology, like unilocular solid, multilocular.
Okay, so you're
solid.
asking me the morphological
Yes,
category
yes.
described by iota, right?
Yes.
So it appears to be solid.
Solid.
No doubts.
Yeah. And we also look at the regular or irregular walls.
That's tricky. That's
Yeah.
tricky because talking about regularity or regularity is a very old question. If we look at the border, they seem to be regular to my eyes, even if they are at time 6, 7. I was uncertain, is it an irregularity or not? But I see a shadow.
Acoustic
there.
shadows, yeah.
And on the right image, again, very difficult to say, regular or irregular because of shadows. So let's go on by saying regular,
or irregular, like a dynamic video maybe would have helped.
Yes, for sure it would be important to have a video clip to check this parameter. Acoustic shadows, yes. So in my report, I will write on the left side, there is a solid mass with these diameters, with regular borders, characterized by the presence of acoustic shadow. Color score, here I would say 2.
Yeah,
2,
minimal vascularization.
Minimal vascularization
I
there.
agree. And in order to assess this patient, and assess this lesion, would you request any tumor markers? Would they help?
Difficult.
I know.
Difficult question because according to pattern recognition, I would say it looks like an ovarian fibroma because of these parameters, vascularization, shadows, etc. Now, the question is, if I plan surgery for this patient, before surgery, I ask for CA125.
Yeah.
And I have to admit, here it seems to be clear as an ovarian fibroma. I hope not to make a mistake. But we can have some strange results. So, in front of a solid lesion like this one, in my mind, I put in my mind also the possibility of metastasis and also another stromal ovarian tumor that we are going to discuss later, I suppose. So here I would exclude metastasis. I cannot exclude 100% another.
You would exclude metastasis because of the vascular pattern?
Mainly, and also, I don't know, is it unilateral or bilateral?
It's unilateral.
Unilateral. This is crucial, because I would exclude metastasis. But again, I have to consider all these possibilities, that possibility, another possible stroma tumor.
So you said benign.
So in any case, I would ask C125 before surgery.
Yeah.
And inhibin B.
Okay. Just because of the differentiation with another stromal.
I don't remember the age of this
52.
lady. 52.
And postmenopausal.
Okay, so we are not talking about the germ cells. I would exclude that because of the age. Okay, good.
So she was...
Shall we want to ask the audience? Benign or malignant? Are you with me? Benign.
Yes.
So no surprise
confirmed.
for you.
It was an ovarian fibroma.
It was confirmed. Okay, done.
Gone.
Let's
young
go
patient, 36 years old, incidental findings. So this is the ultrasound, Antonia. These are the ovaries.
No, I'm saying because looking at the first image, it can be a completely normal ovary to my eyes. The second image, again, difficult to assess. The third image with color,
yeah,
it's a little bit clear, indicative of something strange. But I want to ask you dimensions.
So,
okay,
54 millimeters in the largest diameter, so it's larger.
Okay, in this lady, I would scan this lady with some uncertainties.
Yeah. But maybe now you think that it could be a mass in the ovary, like not an ovarian.
Okay, no symptoms, ovary. Incidental finding, because in front of this shape, not like an almond, a little bit rounded, with quite evidence of these circular cystic areas, I have to think also of torsion.
She's asymptomatic though, and she had no episodes of acute pain.
Okay, time is running, so we have to go.
Yes, so this is a vascularization.
Looking at this image, I'm very much in favor of something malignant.
It's a worrying picture.
Yeah, it is.
So, it was a unilateral lesion. It was not bilateral, unilateral.
Okay, for sure. This one with power is worrisome.
So you would classify as a solid lesion?
Again, a solid because more than 80%. Regular, irregular walls. I would say irregular.
The walls, and like the contours.
At the external border, but also at the wall of the cystic areas. You agree?
I agree.
Regular. Color score, number 4, I would say, looking at the power.
I agree with you.
And then tumor markers. Here, if I have to make a guess, specific diagnosis, I would think stroma tumor.
And you would go for inhibin B, AMH, apart from CA125?
Exactly.
Okay. So we said malignant and stromal. Patient underwent surgery, and it was indeed an adult granulosa cell tumor, 1C.
But this was a difficult case, because at the beginning it was not so clear to my eyes.
That's true.
Okay, so.
Other case.
And this one, again, to my eyes, more difficult. More difficult because 43 years old, incidental diagnosis, and looking at the image on the left, if this is the two images of the same patient, of course.
It's the same.
If I would put on color, and I would have found a strong vascularization inside, like a lead vessel, with that picture, I would make a suspicion of Krukenberg.
Okay.
Especially if bilateral.
Yeah.
Looking at that color, at the other image, that's why it's important to have the video clip to be there scanning the lady. It's quite evident the presence of shadows. The color is little. And so those features are really reassuring to me.
Yeah.
And so in my report, for the description, I would say again solid, more or less solid, with regular borders. If you disagree, please raise your hands. Then acoustic shadows, yes. Color score, 2. And tumor markers, as we said before.
So not really to help in the diagnosis, but maybe also to have an information in addition
to be stored.
For,
yes.
Yeah. So it was a unilateral and 75 millimeters in the largest diameter.
Okay.
CA125 was slightly elevated, 71.
It was elevated. And does it change our mind? What do you say? Please help me.
It's always annoying if CA125 is a bit increased. But,
can we have Walter's microphone? Okay.
That it's also a big tumor, and is there also some free fluid around it? No, I cannot see it.
So no ascites.
Just a little bit, a little amount of free fluid. Yeah, a little amount.
It's not very high, and CA125.
72, and patient is 43, so it's a little bit like. Okay, so she underwent surgery, and it was indeed an ovarian fibroma, benign, but with this atypical appearance.
So which type of messages can we get from these 3 cases?
So I would say solid, unilateral. Sometimes we can have also bilateral lesions, but solid. Maybe we can consider the vascularization, the study of the vascularization. The presence of the shadows can help sometimes. The clinic, I think it's really helpful, knowing if there are any symptoms, but we will go through these symptoms also a little bit later in the presentation. So
we are giving to color a great value to color in this moment. We have to be careful.
I know,
because Adnex, the engineers were able to exclude the color to provide. Yeah. But here,
these are rare tumors.
We are talking about rare tumors. Yeah. But let's go on because the time is running.
So, and here I wanted just to show this case. This was done by my colleague, Mr. Yazbek. So, very young patient with this lesion, more than 6 centimeters in diameter, highly vascularized with some cystic spaces. She was 20.
Okay, very
presented
young.
With pelvic pain and discomfort, but actually she had a personal history of granulosa cell tumor. It was this unilateral lesion, 6 centimeters in the largest diameter. All markers were negative, CA125, alpha-fetoprotein, inhibin B, AMH. Well, of course, the suspicion was very high, so she was operated, and it was confirmed to be a relapse. So just to keep in mind how they can look like the relapses of granulosa, quite similar to the original granulosa, and also the possibility of a relapse also in a very young patient. The importance also of a long follow-up, even if in this case, unfortunately, the relapse was quite soon because the first diagnosis was 3 years before. So, if we want to look at all the ultrasound and clinical features, starting from the granulosa cell tumor, in order to make like a sort of summary, according to textbook, adult granulosa cell tumor represent 1% of all ovarian tumors. They're typical, unilateral, large size, and we can find them in the reproductive and postmenopausal age. They can be diagnosed also at the first moment with hemoperitoneum, just in 10% of cases. They are diagnosed at early stage in the large majority of patients, and the stage is very important because it's a prognostic factor, and they can have a late recurrence. They can have also an extra ovarian spread in the peritoneum, in the omentum, and of course the recurrence rate is higher if there is an higher stage of the first diagnosis. Biomarkers to keep in mind, inhibin B, AMH. They can be often estrogenic, so they can present also with a patient with thickened endometrium or endometrial hyperplasia, and in 5% of cases with low-grade endometrial cancer. And in some cases, they can be androgenic. It's quite rare. And in this case, you would expect a more cystic structure at the ultrasound. Quite rare, though. So if we look at the ultrasound features, just remember that there are all these pictorial papers on the different subtype of tumors. If we look at the series of 23 granulosa cell tumors, here you have the typical appearance, so unilocular solid mass with this typical Swiss cheese appearance, or they can be more solid. And the vascularization, it is usually moderate. Then, regarding fibroma, well, benign stromal tumor, represent 3-4% of all stromal tumors. It is more typical in middle age. It can be unilateral, but also bilateral. It can present usually with abdominal pain, and it can be associated with an increased CA125. It can be also associated in Meiggs syndrome in very scare pictures with bilateral large ovarian fibromas and ascites and hydrothorax and increased CA125, but that's actually a histology, a benign ovarian fibroma. And if we look at the series published in the pictorial paper, so 68 fibromas and fibrotecomas, this is the typical ultrasound features. So solid, round, oval shape, lobulated but regular walls with these acoustic stripy shadows. And they can have also some cystic spaces. This is the most common appearance. Then we can have also the absence of acoustic shadows, or anyway, the absence of these typical stripy shadows. We can have also a clear, dense content with acoustic shadows, so dense calcified content. Or we can have also this atypical appearance of cystic structure
Very
inside,
strange.
as we saw also in our case, or more cystic. And they are usually not so well vascularized, Coro score 2, but sometimes we can have atypical fibromas also with a moderate vascularization. Then I wanted just to show this case, to share also with you, because sometimes we have like these large annexal lesions, and it's very difficult to understand the origin. And in this patient, she was very young. She presented with abdominal pain, and she had this large central lesion, unilateral, multilocular, solid, with more than 10 locules, 40 centimeter, not so well vascularized, but so huge, so large that it was difficult to assess properly the vascularization. All tumor markers were negative. We were expecting something mucinous, horrible. She underwent surgery, and it was a leiomyoma with cystic degeneration due to a torsion. This was a case also seen together with Mr. Jasbeck.
Very useful
to confound the idea. I know, but this is real life, and you see, like, I wanted like to share these pictures taken by Mr. Jasbeck because it was very typical. And here you can find the pedicle. It was really arising from the fundus of the uterus, torsion on the pedicle, and then this huge mass which was seen. So just also to say that in clinical life, then it's not always so easy to make a straightforward diagnosis.
Did she have no symptoms?
No, she had abdominal pain and swelling, yes, absolutely. Wow, there.
Interesting case. I also added 2 cases just to show you that you have to think also outside the ovary. So this is the first case. She's premenopausal and she presented with irregular bleeding. And the first thing we saw was a thickened hyperechogenic endometrium. Besides that, she had this big ovarian lesion, also multilocular with some small solid components. Some locules were very anechoic of contents, others had ground glass and some hemorrhagic appearance. But you can see also here this Swiss cheese aspect, I think. So moderate vascularity. And so she had also a slightly increased anti-Mullerian hormone. We also took a pipal biopsy of the endometrium to exclude any malignancy. She underwent surgery, and it was a stage 1A adult granulosa cell tumor. And in the pipal of the endometrium, it was an endometrial hyperplasia without atypia. And then another patient, she was postmenopausal. She presented with postmenopausal bleeding. The same story, also a thickened endometrium, and also this large adnexal mass with Swiss cheese aspect, vascularity. And this patient, the tumor was 11 centimeters. The markers we took, so we didn't take here the anti-Mullerian hormone, but only CA125 and CEA. CEA125 was slightly increased, and it was also confirmed at surgery a stage 1 adult granulosa cell tumor with an hyperplastic endometrium. Just to show you that these patients often have bleeding disorders or irregular bleeding or postmenopausal bleeding. So also if you have patients with this symptom, you have to think about a potential tumor in the ovary.
So you always, sorry.
No, at the beginning I thought that granulosa is typical of a perimenopausal age, but we found so many cases also in young ladies, So in front of these lesions with several locules and solid component, we have to think of that. And several times we do not ask for inhibin B and AMH. So this is a key message.
What about the size? And some I have seen a patient that had a very small granulosa cell tumor, so they're often said to be very large, but
sometimes, yes.
Can be also very slow. Or what is your experience on the size? Have you seen small granulosa cell tumors, or are they always large?
No, not really. I don't remember many cases of smaller. I remember usually large. 8, 7, 9.
I saw one case of small granulosa.
Only one case?
Only one case. With a small granulosa, postmenopausal patient. It was just solid, vascularized. But I didn't think about granulosa. So indeed, I didn't ask for inhibin B in that case, but it was an adult granulosa in stage 1A, yeah.
Okay.
Very, very small. So you could see something in the ovary. You could delineate this solid lesion. It appeared like something stromal, but not so straightforward for granulosa.
Before moving to the second part, I want to ask you, do you think that there is a space for radiomic to differentiate an ovarian fibroma from other malignant lesions, solid, in this so difficult category of solid tumors?
Well, there's a lot of solid tissue to look at, and maybe the aspect of the solid material can be interesting to look at some subtle differences. Check. It should be interesting.
We will see in the future.
I think that, yes.
Okay, water.
I wanted just to underline something. So every time that you scan a patient, postmenopausal patient with thickened endometrium, postmenopausal bleeding, you also look at the ovaries.
I think you have
just
to look at the
sure
ovaries.
That you're not missing anything. Yes, yes.
Definitely.
Yeah.
I think we are about on time. We are on the half.
Yes.
Perfect. So then we will move from the stromal tumors now to the germ cell tumors. And in this group, we will discuss the dysgeminomas and the immature teratomas. Chiara.
Let's start with a young lady, 25 years old, presenting with abdominal swelling. So she had this large lesion. So there should be a video. That's the one on top upper corner on the left. If you can click on this, please. Technical support.
Because again, we are in front of a solid tumor. Let's look at the surface.
Upper on the left. Yes.
Okay, thank
you. Because here you can see clearer the appearance. Antonia, you have to guide us in the description and the assessment. So I want you,
Difficult to say because, as we have just said, let's start with the ovarian fibroma. If we look for shadow, we can find the shadow. Can you find it? Okay,
yes.
And it's different to say why to my eyes it's not an ovarian fibroma, but it's not. I cannot tell you, I cannot explain why.
Is it the shape?
The shape.
Is the shape like this elongated?
Lobulated, the age, but also the structure. It's difficult to say. I cannot explain as a cooked, but the structure is different. You have to admit that it's not like an ovarian fibroma. in any case. So vascularization, I would say moderate, 3, color score 3.
At least, yeah, I agree.
Always in young ladies, it comes to my mind, dysgerminomas, germ cells, something among germ cells, so immediately. So instead, for ovarian fibroma, also the age. Usually the ladies are 40, perimenopausal, etc. Young lady, I think of that. And if I consider what we learned of these germinomas, you remember we discovered that anatomically the pathological textbooks taught us that they are characterized by septa within a solid lesion. If we look at that, do you recognize the septa? You do. And to me, I would make a suspicion of this germinoma.
So
not granulosa,
yeah.
for instance, because usually you find some cystic areas.
Yeah.
So here, I would exclude ovarian fibroma, but I don't know, it could be. I would exclude granulosa, and what else? Metastasis, it could be. But again, unilaterality can help.
Unilateral young patient, unilateral large solid.
Germ cells, you have to think of that.
Okay, yeah. Fine, so we discussed regarding all these features. So you would request some
tumor markers completely different. For sure, always SCA125, but again, alpha-fetoprotein, HCG, LDH,
Yes.
this one.
Yes. So this was the vascularization. This could be maybe a little bit misleading with this strong vessel inside.
Yeah, I wanted to stress that I described the lead vessel for metastasis, but I haven't tested this sign prospectively, so we don't know.
No, but it's also, as you said, like it's unilateral, it's young, it's so it's a mix of information that you have to take into account always. Yeah. Okay, so we said malignant. It was almost 20 centimeter in the largest diameter. Serum CA125 was the only tumor markers which was measured.
So I don't know who was the clinician, they didn't test it.
No. I scanned this lady just before the surgery, before the operation theater, because I really wanted to look at this ultrasound, and I had no possibility to request additional.
It happens.
It happens, yeah. She underwent surgery. It was a dysgerminoma, stage 1A.
So here it's very clear, the lobulation.
Sorry.
There, you see?
Yes.
At 3 o'clock, 2 o'clock.
You can see.
So you mean that there's more hypoechogenic round structures and surrounded by hyperechogenic septa? Or how do you describe it?
I didn't notice that. Only lobulated so far. We needed to collect
see round
them.
structures inside. That's what you mean, or?
But there is a little bit of confusion with the idea also of metastasis, because I learned from Daniela, because I didn't notice that in a solid metastatic tumors, you can see these nodules corresponding to the spread of metastatic cells growing. So none of us did a prospective study checking metastasis and dysgerminomas. At the moment, we have just described what we observed.
Yeah. This is also what is very interesting regarding ovarian masses, because you can never get bored, no? There is this large variety, and unfortunately it's always challenging, and you need really always to consider so many different possibilities. And So, yes, dysgerminoma. So we can go on with the next case. We mentioned Daniela Fischerova. This is a case that she scanned.
Okay.
And she gave to me, very young patient, which was, in my opinion, very weirdly asymptomatic. So it was an incidental finding.
It's huge.
This is very
I notice in this picture something that is very difficult to describe. The adjective I would use, bizarre. Do you like bizarre?
Like Prof. Valentin.
Valentin. No,
Yes.
Professor Valentin taught me how to notice irregularity. For Professor Valentin, the adjective irregularity is the most important parameters when you want to discriminate benign and malignant. But then, looking at this one, bizarre.
And irregularity, you mean the ecostructure?
Everything, ecostructure, everything.
So not only like the
Yeah,
borders,
yeah,
the
yeah.
contours, but really the ecogenicity.
But here, what I wanted to emphasize is this structure that I tried to describe in a strange manner, mentioning an Italian food, tortellinos, but for my colleagues it's difficult to understand what I mean. And then Luca Savelli taught me and other colleagues, he noticed these hyperechoic areas with shadows behind. Again, irregular, different, and to me, I hope to be right, it corresponds to the presence of neuroepithelium. And so another germ cell tumor, that is, shall we want to go? Immature
Yes,
teratoma.
immature teratoma.
Immature
So
teratoma.
keep in mind this echogenicity, this image of anechoic cystic structures with these hyperechoic areas, with these acoustic shadows, because this is the most typical characteristics of the immature teratoma. Yeah, so we went the all.
What's is really reassuring is that there is no possibility to confusion between dermoid and immature teratomas.
Yeah.
Even if perhaps there should be some cases, but usually immature teratomas, and you are collecting that.
Yes,
you are
we
going
had
to
just
describe
one case, which was
one case,
a little bit
okay.
tricky, but in the
usually-
vast majority, they are quite typical.
Typical what? Typical
Immature.
dermoid or typical
They are
immature?
typically immature teratoma,
Okay.
so you won't be in doubt with the benign. But one case was tricky. It
Do
was
you
more
agree?
cystic, and it was
I was
tricky.
just wondering, do you ever see hair, like the lines and the dots? Do you ever see hair in an immature teratoma?
So there can be component of dermoid in an immature teratoma. So it's possible. I don't know. We don't have like a clear A represent in our series.
And this is something that I don't know, because the definition, you're going to do the theory. Would you
Yeah.
like to explain the theory so we
Yeah,
can discuss
absolutely.
later about that?
Here, just to show you the markers, were all negative, the LDH, HCG, alpha-fetoprotein, and then we had elevated CA99 and CA125.
This is very strange to me.
This is strange, but also in my series
Which series?
of immature teratoma, I'm
How
working
many?
with this together with Prof. Valenti.
How many?
More than 40.
Wow.
Yes.
And did you find
And we-
elevated CA?
We have also, when measured, a high percentage of CA99, which was elevated, and CA125, which was elevated. But this is something
In
that
actual
I
fact,
expect.
we know that CA 19.9 is elevated also in dermoid.
It can be elevated also.
Yeah. So perhaps, okay. Sorry.
So, yes, here there is no hype anymore because it was an immature teratoma, grade 1, stage 1A. And here it's amazing how you can see the appearance at the macroscopic specimen, and you can compare how it looks like with the ultrasound. Okay, so if we go through the textbooks and the ultrasound features, digerminoma is the most common malignant germ cell tumor. Usually, we said unilateral, large, solid, and it is very rare before 5 and after 50 years old. So very common in young patients. Biomarkers, LDH, HCG, they often present with abdominal swelling because there is this large abdominal mass. And the prognosis is quite good. So the 5-year survival rate is almost 1% for all stage 1. And it is anyway very high for all the other stages. If we look at the pictorial paper, 21 digerminoma, they were large, solid. We mentioned lobulated, and we talked regarding these lobules. So here, the arrows will show you these lobules. But they can look like in a different way. Sometimes they are more obvious, sometimes they are not really obvious. So this finding can be tricky. But as you mentioned, Antonia, indeed, the ultrasound appearance was not the ultrasound appearance of a typical ovarian fibroma, at least.
No.
There was some heterogeneity. And they are usually moderately or highly vascularized. Sometimes they can be also with these large cystic areas with some papillary projections, but this is a less common ultrasound finding. What about immature teratoma? So, according to textbook, unilateral, large, and increased alpha-fetoprotein, young patient, and it is based on the presence of immature neuroectodermal tissue, and according to the amount, it can be graded in low grade or high grade, and this is important for the prognosis. And we collected 42 cases. We had also some older patient. 50 was the eldest.
By the way, there is a question from home. Do you consider to be young till menopause?
This is a good question indeed. We don't know, we don't have a cutoff for young. This is correct. All these patients, though, were premenopausal. This is the only thing that we know, even at 50. And they presented with this unilateral large lesion. And alpha-fetoprotein was increased in 12 out of 20 where the alpha-fetoprotein was measured. And indeed, they can be solid or cystic with large solid lesion. And here I wanted just to show all different types of immature teratoma just to be used to this echogenicity, to the bizarre echogenicity. And also to the presence of vascularization.
Can you recognize the tortellinos here? Please say yes. Those are circular structures.
It's tricky. We have to work on this typical feature. So you can see some vascularization, which is not so increased. So you can have usually a vascularization like Coro score 2, minimal vascularization, or moderate vascularization. So vascularization, which is something which is not typical of dermoid. So presence of vascularization, but not so rich vascularization, which is something that you would expect in a malignant lesion. And here it's just like minimal vascularization or moderate vascularization. And here, just to show you different cases with like larger or smaller solid component, but all with this typical ultrasound appearance.
Sorry, in the previous image, it's very clear on the left image, this hyperechoic with shadows behind.
Yeah. And here you can see vascularization is present, but it's not so highly vascularized and richly vascularized how you would expect for a malignant lesion, for example. And Wouter.
We have a couple of minutes left for some cases, and maybe you can also ask the audience what they would think about these masses.
Why not?
So this is another case. I will show you first the grayscale images. Solid. Irregular lining, maybe. The vascularity. 4. Who thinks it's benign? Who thinks it's malignant? And now, would it be a granulosa cell tumor?
No Swiss cheese.
No Swiss cheese. A fibroma of the ovary. But there are some shadows there.
There are shadows. The shape is a little bit...
And no fan-shaped shadows.
No fan-shaped. And high vascularity.
Vascularization is very...
What about an immature teratoma?
No.
Is it bizarre?
No. Bizarre in a different manner.
Do you see tortellini?
I will...
So we really... Because of vascularization, I would exclude the fibroma here.
Yeah.
What do you think? Usually, even if sometimes there is a question over there. Can you go to the microphone for the question?
Is it working? Yeah. Hi, I'm Magnus from Stockholm. You can see this image, you have some branching vessels.
Yeah.
Consider that as well, because that's what strikes you when you look at the vascularization.
Exactly.
It's not only a grade 4, but it's also with like a very branching tree of arteries and vessels.
Yeah. And because of that, what do you think?
I'd say quite malignant.
Malignant.
And from your, can I say, from your lecture, I'd say a dysgerminoma.
Dysgerminoma. Wow.
We will see.
Let's check.
It's
I don't know.
unilateral.
Water, are you really satisfied?
I'm satisfied.
Yeah, please go ahead.
It's a malignant.
Let's check.
So,
You're right.
additional information. The patient was, she was young, she was 25 years old, was unilateral, irregular solid, 9 centimeters, shadow.
The age, sorry?
25.
25.
Yeah. And then we had some tumor markers. You can see that there is not a lot too high, maybe ACG,
Slightly, really
slightly elevated. She underwent surgery, and it was indeed the geminoma. She had a 3A, and the reason was that she also had a lymph node which was enlarged, and that was also removed, so there was a lymph node metastasis. 44 seconds.
Yes.
Yeah, but then we
For
have
the
other
last
3
case,
minutes.
please go ahead.
We have another 3 minutes for questions, for discussion.
All right, this is also a young patient, 25 years of age. Who says it's a dermoid? Benign. I hear immature in the audience. Let's show you some more images. Do you agree that it's multilocular solid?
Yes, we do.
So there's the septum, and we have a solid component. Do we see some shadows?
Yes.
Yes.
There below. Let's see how we described it. So irregular multilocular solid, it was 27 centimeters.
Wow.
The largest solid component was 10 centimeters. Color score 3 we gave to it. No ascites, shadowing present. C125 was 247. And then alpha-fetoprotein was 16.9, was increased. So she underwent a laparotomy with staging. Who thinks it's an immature teratoma? Yeah.
So now it's really like that solid component with that appearance
black.
of the solid component with all the ultrasound features, which really guides us, no, in subjective assessment.
Here you see the macroscopic image of the solid component.
Shall we see here?
We didn't see hair.
Straight.
Now we're interested in the air. We have to ask
The pathologist,
pathologist.
the pathologist, because as you mentioned before, there is a grading, grade 1, 2, but you know...
according to the neurodermal tissue.
But according to what, you know? According to the amount.
Yes, according
Not
to
the-
the amount of the immature neuro tissue,
Excellent.
yes.
So if it's based on the percentage of immature neuroepithelium, it means that there are the other components.
Yes,
So,
yes.
but to my eyes, I don't remember cases with the typical sebum Rokitansky
Or a
nodules
white
over
ball,
here.
yeah, indeed.
So we will ask.
It was a low-grade immature teratoma. I think we are running out of time, so Chiara, do you want
Did
to
we?
summarize?
Yes, so if we have to just say a few words regarding this germinoma,
I
which
close my
ultrasound
eyes
features-
and I say unilateral dysgerminomas,
this germinoma.
unilateral solid septa, young, not menopause, young, 25, 16, etc. LDH, alpha-fetoprotein, and that's it.
Yeah. HCG can be also increased. Yes.
And,
yes.
yes.
Germinal. And Wouter, if you think about immature teratoma, we have just discussed regarding this.
Young patient, very large tumor, a large solid component with heterogeneous or bizarre appearance, tortellini sign,
Unilateral or bilateral?
unilateral.
Yes,
Yeah.
let's keep in mind stromal and germ cells always unilateral.
So you can have bilateral lesions in immature teratoma, but the contralateral, it is usually a benign dermoid,
Ah, yes, that's true.
something which
Good.
is described, but not bilateral immature teratoma
And then tumor markers are alpha-fetoprotein.
with the protein.
Yeah.
Yeah. And for granulosa,
Me?
yeah, Antonia, yes.
So solid, Swiss
we have
cheese,
to.
Monolateral, low potential malignancy, inhibin B, AMH, and late recurrences.
Yes, so long follow-up for these patients. we finished.
Thank you. I have one interesting comment from
Yes.
the audience at home. The tortellinos are usually delicious, not like what this one would taste like.
This is a
Grazie mille.
very right comment.